so that I can share with everybody.
This meeting is being recorded.
Okay. So hopefully everybody can see what I can see, which is the beginning of my slides. So I'm Angela Wright. I'm a GP over in North Yorkshire, and I work at the Menopause Clinic in Hull 1 day a week. And I'm a GP, a menopause specialist, and I'm trained as a clinical sexologist, which always sounds like a bit of a made up term, but it means that I've had a couple of years of psychosexual therapeutic diploma training. And then as a doctor, I felt like I needed to understand a bit more about the medical side of what went on with sex at menopause. So I've also gone and done the ESSM Advanced School of Sexual Medicine in Budapest and taken membership exams. So I've got this kind of slightly unusual job where I understand what might go on with people psychologically when sex becomes a problem, and also what might be going on in their body with, disease processes and medications and all that kind of stuff that also makes a difference. And I did that training first without really thinking about menopause very much. But when I came back into general practice, I found that I was using it all the time in the women in my practice who were going through the menopause transition. So that's when I joined up with the BMS and did my advanced menopause training. And I've ended up finding myself kind of working in this area where the two things cross over. And I have a bit of a mixed week. I'm still a GP, but I work in primary care, secondary care, do some private work, and I also work in a voluntary way with charities like Maggie's. I'm an ex-hospice doctor, so I sometimes use that kind of combination of skills to work with women who've had induced menopause and who are having problems with sex as well. So what I want to cover today, and I'm aware that I'm talking to a mix of healthcare professionals, non-healthcare people, people that are going to be patient-facing, people that are going to be experiencing menopause themselves. So I want to make sure that what I leave you with today is some understanding about sex and menopause and why it comes up so often at this stage of life, and why it's really important that we talk about it. So as health professionals, that we raise that subject with our patients, and also that we look at the problems that people have with sex from something called a biopsychosocial perspective. So I'll explain what that is as we get a little bit further into the slides. I'm going to talk about some of the body changes that happen as we go through menopause and some of the treatments that we've got that can help with that. And I'm also going to talk about some of the stuff that goes on in our lives and in ourselves and our sort of sense of identity and confidence and so on, and why those things are also really important when we're talking about sex. Because I hear, when I look at what's happening in social media and I look at people talking about sex in that sort of bubble, I hear a lot about testosterone, but I don't hear a lot about some of the problems that I end up dealing with day to day in clinic, which are much more psychosocial. And I think the whole thing kind of fits together. And I'm going to do it by trying to bust some myths as we go through the talk. There's quite a lot of stuff to cover, so I've got time for questions at the end, and I'm really happy to hang around until up to about 2 o'clock to answer questions if people have got them. And just before we started, my computer switched off randomly, so if I do disappear at some point, I will come back. So apologies, I don't quite know what happened there. So number one myth is that sex is not a really important issue and it doesn't bother people that often, and that sexual issues are pretty rare. So we do studies in the UK. We do this series of questionnaires called the NatSal studies, which are a sort of a national survey of sexual attitudes. And what we know is that the way that we think about sex as a population is probably not quite in line with the kind of sex that people are having and the kind of problems that people are having in their lives. And when we talk about sex, we sort of talking about penetrative sex, but actually we know that penetration is not that necessary for satisfaction, and that people who have good quality sex lives tend to be people that have better general quality of life scores as they go into middle age and beyond. And bizarrely, sexual function, when you look at it and study it, it maps pretty closely with life satisfaction. So we know that as we get older, the quality of sex is more important to us than the quantity. In men, apparently, it's the other way around. But if we have 100 orgasms a year, that's associated with a longer life expectancy. Some studies show that up to 3 to 8 years of extra life. And part of that is the impact on quality of life. And part of that is to do with the fact that your body has to be pretty healthy to have good sexual function. So the two things are quite correlated. And we find that for those of us that are in practice, our patients don't tend to raise the problems with us. We have to ask about it specifically, but lots and lots of the patients that we see in clinic and lots of your friends and colleagues who are going through this transition will be experiencing problems with their sex lives, even if they're not talking about it. So the NatCell study showed that about 1 in 6 of men and 1 in 6 of women will have had some problem with their sex life in the last year. About 1 in 4 people are in a relationship where they've got some difference in the amount of interest they have in sex with their partner. And then we know that probably 40% of men and slightly more of women have experienced sexual difficulties and are feeling distressed and worried about their sex lives. This is pretty common. And I also realized when I did my sexology training that so much of the training that I'd received had been really what we call heteronormative. It was, as a doctor, I was very much taught about the sort of basic relationship being a male-female relationship, a monogamous relationship. And that tends to sort of feed into lots of biases when we're talking to people as healthcare professionals in whatever role we might be in. So it's important to recognize that things are shifting in our society. Women at midlife are not the same as they were 50 or 100 years ago. There's a decline in the number of us that are married at this stage, and the number of people that are in second and third relationships is growing. There's a lot more that identify as non-binary or in different relationship structures. And it's important to recognize that it's not only people that are in relationships that we should be considering the importance of sex with. For many of us, our solo sexuality is also really important. So just because we're not in a relationship or we might be divorced or widowed doesn't mean that sex isn't of any interest to us. So I think one of the biggest myths around sex is that it's all a body-based issue. And as long as we keep the body working, then sex is going to be okay. So what are the sort of definitions we have for sexual dysfunction? Well, I don't like labels very much. And one of the reasons that I think that some of the definitions we have for sexual problems across the board, really, not just at midlife, need to be questioned is that they don't really take into account the differences between the people that they're studying. So everybody, as they grow up, has a different level of access to education about how your body works and about sex. We have different levels of access to help for problems that we might be having with our sexual health. And the kind of worlds that we grow up in, whether we've got strong religious backgrounds or cultural norms, how much freedom we have as women in our societies, what our relationship dynamics are like, how safe we feel within our relationships, who holds the power, and whether we've had any history of trauma. All of these things are really important in how easy it is for us to access our sexuality in a healthy way. And we have to think about all of those things. When I'm tackling problems with sex, I have to put it into that context. And just for those of you who are patient facing and those of you who haven't, but also have some background history of trauma, I just wanted to take a second to recognize that trauma is something that's pretty common and it does have some interaction with sexual problems. So we know that in the UK, something like 1 in 4 women has had a previous history of some form of sexual violence, 1 in 6 men. Not all trauma is sexual trauma. There's trauma to do with abusive relationships, traumatic bereavements, medical trauma, surgical procedures, and so on can all give us traumatic experiences. But trauma is a really common thing to have in our psychological history. And where there is trauma, there's crossover with problems with sex. We see more of something called vaginismus, which is where the vaginal muscles tighten and penetration can become really painful. But we also see more problems such as loss of libido or difficulties with arousal and climax or sexual pain. So if you're dealing with patients on a day-to-day basis and you're watching this webinar and you're in a patient-facing role, I just want to encourage you to remember that some of your patients may be bringing that into the room with them, and to make sure that you make it really clear when you're examining them that they hold the autonomy of that process, and just to ask whether or not you can do something to make examination any easier. So does everybody know what's normal, and does everyone agree with what's normal when it comes to sex? When I did my training, I had the concept of something called sexual scripts explained to me. And as psychologists have scripts for everything, the scripts are, it's a definition of something that is an unconsciously absorbed, internalized sense of what's normal. We have them about all sorts of things, and we have loads of them when it comes to sex. And I would ask you all to think for a second about how you came to know what you do about sex. And very quickly you'll realize that what you learned was from school, from your parents, from the media, from sex education lessons, if you were given those, from watching Hollywood films, maybe from pornography, maybe from your own experiences. And it starts to give you a sense that actually everybody, when it comes to sex, is looking at it of a slightly different lens. And our ideas of what a normal sexual repertoire is, how frequently we should think about or have sex, whether or not monogamy is the desirable thing to have, or whether it's something that's easily achievable, our sexual preferences, all of these things will differ slightly depending on the early experiences we had and the early education we had around sex. And where we feel that we're different to what we think is normal, often that's a source of shame or low self-esteem for us. And I think it's really important for those of us that are consulting to understand that our ideas of what's normal with sex are going to differ from what's normal for our patients. So we shouldn't have an idea in our head of what normal sex looks like at middle age or what normal interest is like for a woman as she goes through her menopause. It's going to differ for everybody. And sexual scripts really matter in practice as well. Many of the women that I see in the clinic have got a sense that something's wrong with their bodies and they don't work normally because the sex that they're having is not working in the same way as the sex that they've seen. We've got huge gaps between orgasm levels in men and women in heterosexual sex. We know that if women and men engage in solo sex for a few minutes, about 95% of people can climax. But when we put men and women together in heterosexual sex, according to kind of normal scripts of penetrative sex, men will climax about 95% of the time, but women will climax only about 65% of the time. And in hookup sex with a new partner, the female orgasm rate goes down to 18%. So that shows you that it's the kind of things that we do, the kind of things that we think are normal for sex, that make a big difference to our experience of sex. In contrast, when women have sex with other women, the orgasm rate's about 85%. So this understanding that penetration is kind of the center of everything is something that maybe we need to question a little bit when we look at women's sexuality. So how is it that we're supposed to look at sex? What is this biopsychosocial lens that I'm talking about? So this is the idea, it's a Venn diagram really, that when we're experiencing problems with pain or with loss of libido, difficulties with arousal, loss of lubrication, or difficulties in having an orgasm, that rather than just focusing on what's happening in somebody's body, which we do need to look at, but we should also look at what's happening in their mind and what's happening in the world around them and in their relationship. And it's that kind of jigsaw puzzle that we need to put together when we're trying to figure out what's going on with sex when sex has got a problem. So if we look at menopause in particular, if we think about what's happening to the body, there's this thing called GSM, which I'll talk about in more detail, but it's genitourinary syndrome of menopause. And that's all the changes that we see in the vagina, the vulva, the bladder, the pelvic floor due to the change in hormone levels. The changes in hormone levels generally also have an impact, not just testosterone, which we're hearing a lot about at the moment, but also estrogen. Our general health matters and the medications that we take, whether we've had a history of something significant like cancer and had surgery, and our partner's health can all impact how sex is experienced. In terms of our psychological well-being, so menopause is an identity shift. We go from being fertile to non-fertile, whatever age we go through. And that shift in identity can impact our sexual identity and how we feel about ourselves as a sexual being. We can get real challenges at this stage with self-esteem and body image, and our hormones sort of conspire against us in terms of making things more difficult for anxiety, stress. And actually there's quite an interesting overlap that says that women who've been through trauma have a more difficult time as they go through menopause. So these issues sometimes really come to the fore in this transition and they can impact on sex. And then socially, it's things like what's the state of our relationship if we're in a relationship? You know, what happens in long-term relationships to desire? What about our caring duties? Are we running around like crazy and we haven't got time to think about sexuality? What are the cultural and religious messages that we may have received about what's normal about sex at this stage? And what's happening with our partners? All those things are going to impact all of the sort of list of problems that I've got there on the left-hand side. So if we start with the body stuff, which everybody tends to talk about more in menopause, I think, what I think is really important to understand when we're looking at the changes of menopause and how it impacts sex is just how clever our bodies are in our fertile years. They're so adapted to try and help us to become pregnant and support a pregnancy. And there's loads and loads of changes in where the blood flow goes and the way that estrogen makes parts of our bodies behave that helps us to have good sex lives. So we get better blood flow to our breasts and to our pelvis. About 30% more blood in our fertile years flows to those areas. And we get even more blood flow when we're sexually aroused. So it helps us to experience better touch and better pleasure from those areas. And that can change. The times that we want to have sex and our interest in sex, if we map it through the month, it maps very closely to just before we ovulate. So when estrogen and testosterone are at their highest, that's when women tend to be more interested in sex. The vagina is really well adapted to accommodate penetrative sex. So it's stretchy, it's thick, it lubricates really well, it gets good blood supply. We get more blood that rushes to the vagina when we're aroused, which means that we get wet, which helps to lubricate during sex. And the lining of the vagina changes every 4 hours or so. So if we do get little bits of damage from intercourse, we repair really quickly. And the cells that slough off are rich in something called glycogen, which means that they feed the lactobacilli, which is a bacteria that lives in the vagina. That keeps them prominent in the vaginal biome, and it means that our vaginas stay slightly acidic, which fights off other infections and stops us from getting UTIs and vaginal infections every time we have intercourse. Just like men, we get reflex erections of the clitoris. So at night time, several times a night, your body's flushing this tissue through to keep it healthy. And we have dense sensory nerves so that touch can be felt really well and we can respond to pleasurable touch. And at menopause, as you've probably heard already this week, we get these big fluctuations in our estrogen levels. Sometimes we get surges as well as dips. So sexual interest can kind of rise as well as fall. We get a slower fall off of androgens like testosterone. And these changes directly impact the brain, and so the central pathways and what we would call the peripheral pathways, the blood vessels, the wiring through our body that control sexual arousal and sexual desire. And we get lots of changes in the genitals and the bladder and the pelvic floor, the breasts, in our skin and in our brains in response to those changes, which means that things can feel different and parts of us will work differently. So the blood supply to the pelvis falls, which means it's more difficult for us to get lubricated. The tissues in the vagina and the vulva can thin by up to 2/3, meaning that they are really quite fragile and they don't stretch as well. The bladder gets thinner and the sphincter, the muscular sort of circle underneath the bladder that keeps us continent, that gets weaker. So it's easier for us to get leaks and problems with our bladder. And we get less glycogen storage in the vaginal cells, which means that the bugs that live in the vagina change and the pH rises, so infections get more likely. And the clitoris shrinks, and no one really talks about that, but over time the clitoris gets smaller. It's one of the reasons we didn't know the full extent of how big it was until we had MRI studies in 2005. And that means that it's more difficult for us to get aroused into climax if we don't do anything about it. So for those that are working clinically, it's important to ask directly about whether patients are experiencing any changes in this area. And I just want to say that although there are physical changes which can show that you've got atrophy, so you can see some of the external structures can shrink a bit, the vagina can look a bit paler, there can be these little petechiae, these little sort of pinprick red marks that are visible in the tissues. It doesn't always correlate. Some women have a fairly normal looking vulva and vagina but have really significant symptoms, and the other way around can be possible too. So we've got to listen to the patients, listen to women who are telling us how things are rather than telling them what we can see. And sexually, all these changes can cause us significant problems. So it's not by accident that I've done a ring of fire in the corner. We can get pain, we can get dryness, we can get tears, the skin can split. We can get painful sex, which means that then we can develop vaginismus, which is this kind of reflex of the pelvic floor muscles shutting, which can make penetration almost impossible. Loads of women get bladder problems and they don't tell their doctors and physios about it, particularly unless we ask, but there's massive crossover with sexual function. I see lots of women who are scared of losing urine if they climax, so they won't let go. The weaker pelvic floor means that we're more prone to incontinence and prolapse. We can get a weaker orgasm if we don't look after our pelvic floor. It's that muscle that contracts when we climax, so it's important to sort of be aware. UTIs can be a problem. So when you do bother to have sex, it can mean that you get an infection straight after. And men and women, their bodies get less good at receiving sensation as they get older. So it can get more difficult to get aroused, more difficult to climax. So we get real impacts on sexuality. And again, for those that are practicing and are prescribing, be aware that no one ever told me as a doctor, but loads of the drugs that we prescribe routinely, loads of the medications that others listening may be on can have a direct impact on sexuality, both the meds that you take and the meds that your partner takes. So antidepressants can cause problems with climaxing. It can make it much slower, if not impossible. We actually exploit that in men to try and help with premature ejaculation. Blood pressure drugs, painkillers, Parkinson's drugs, antihistamines, IBS drugs, hormonal contraceptives, GnRH analogues, loads of things that we give people. It's about a 5-page list of drugs that can impact on sex. So if there's a problem, it's well worth going back to the medication list and having a look at what's on it and checking out whether it might be impacting. So what I recommend in terms of treatment is that we think about whether patients want to go on to systemic treatment. So, you know, for women listening that are thinking about this from a personal perspective, there's a decision to be made about whether to go on to HRT or not. So that's one of the sort of decisions to make, because going on to HRT will help to maintain blood supply to breasts and into the pelvis. We need to make some decisions about whether we stop or change other medications to see if we can support sex a little bit. It's really important to optimize other health issues. So things like diabetes, which impact blood supply and nerve function, have a big impact on sexual function. It's not just men that get erectile dysfunction on the back of diabetes. Women's sexuality is negatively impacted too. The tissue of the penis is derived from the same bit of the fetus as the clitoris. So the kind of wiring and blood vessels is very similar between the two genders. And those with heart disease and painful conditions, those things need to be dealt with. We use our body as a tool to have sex. And if our joints hurt, it can limit what we can do and limit the attention that we can pay to what's happening in our body. And we have to think of the partnership as a whole. So when we're looking after one side of a sexual relationship, we have to make sure that we're thinking about what's happening in the other side too. For women, actually, partners' sexual function is one of the biggest impacts on our own sexual satisfaction scores. So looking at people as a whole is really important. And then we've got to think about what we do locally in the genitals and the pelvis. So I'll go through this in more detail over the next few slides, but I tend to advise everybody to kind of do a ritual of self-care, really sort of looking after your vulva a bit like your favorite cashmere sweater. So it's quite important to look after it, to think about local hormones, to think about things like lubricants for sex. I tend to recommend the Yes lubes. And we layer them up in psychosexual medicine. We give oil-based lube to women to use as sort of a base coat. And then we use water-based lube on whatever's penetrating, whether that's a toy, finger, partner. And that combination is called double glide, and it's much more slippery and it lasts for much longer during sex. The only people that can't do that are people that are using latex condoms, because oil-based lubes can they can break down latex in condoms. We need to look at what's happening with pelvic floor muscles. So sometimes they're too tight because there's this kind of vaginismus and there's this tension that makes penetration really uncomfortable. But sometimes they're too relaxed, which means that there's leak and prolapse and problems with orgasm strength. So pelvic floor physiotherapy referrals, gynae physio referrals can be incredibly helpful. And then people like me that are sort of specialists in it, sometimes I use drugs like Viagra off license in women with really good impact. So it's something to have on your radar that that's possible, and sexologists and sexual medicine specialists are starting to use that more often in female-bodied individuals. So I think you've probably had webinars already this week about HRT and the pros and cons, but I guess my take-home message on this, I've only got one slide on it in this talk, is that very few of you can't have it. Very few of our patients can't have it. The contraindications list is much smaller now than we thought it was maybe 5 or 10 years ago. And that we need to look at straightforward HRT first when it comes to sex. It's really important to estrogenize women adequately to get the blood flow back in the breast, back in the pelvis, to make the tissues respond better to touch and to kind of prime the brain for sexual interest. And then think about testosterone afterwards if it's needed. We know that most women should be on the gold standard now, really, of body identical HRT, usually through the skin, and almost always with micronized progesterone as a first line, because that seems to have a lower impact on breast cancer risk. It's probably a neutral impact on breast cancer risk for at least 5 years. And that combination is safer in women that are more prone to blood clotting, have got a history of migraine, and so on. And even those women that are using the synthetic progestins, we know that the impact on breast cancer is less than having a large glass of wine every night. So the risks and benefits need explaining and individualizing to women who want to sort of think about this as an option. But it's certainly an option for more women than often think it is. And where HRT isn't appropriate, then we need to make sure that we're looking at other ways that we can help women to manage some of the impacts of menopause, which will then have a knock-on impact on energy and interest in sex, like sleeping and flushing and anxiety. So there are some non-HRT drugs that we can use, although some of those might impact on sexual functions. We've got to think carefully about which ones we choose. What about cancer history? So I do quite a lot of work with Maggie's on a voluntary basis and speak to lots of women. And for those of you with a cancer history or who might be working with women, I'm hopping onto a Maggie's call after this actually to help them with their menopause workshops, but they offer free at the point of use workshops for women with a cancer history to take you through the impacts of induced menopause, including on sex. So that's a really useful resource. We're going to see loads more women who have survived cancer in the next 20 years. The estimate is about 1 in 5 women by 2030 will have had a cancer diagnosis and will be living with that. So it's a big proportion of our patients. And that problems with sex is probably the 3rd most common issue that cancer survivors struggle with. So after fatigue and loss of physical fitness, their sexual function really bothers them. And about 22% of couples will split after cancer. So it's got a really big impact on relationships. But we rarely ask about it as health professionals. And it's rarely brought up by patients because they feel, we've done some studies on it actually, and they feel bad about asking about something so trivial after having gone through something so significant. So it's really important that we kind of take it to patients and we raise the issue with them. And many of those patients will go through a treatment-induced menopause, which can be much more severe than a natural menopause, and they'll have untreated vaginal symptoms because lots of doctors are really nervous about prescribing in this group of women. So just as a sort of take-home message, systemic HRT is more often an option than people realise. In estrogen-sensitive breast cancers, it's very much a last ditch that very few people get offered. But in cervical cancer, endometrial cancer, ovarian, vulval, in women that have got a non-hormone receptor positive breast cancer, it's much more possible to talk about systemic HRT. And for almost everybody, the vaginal estrogens are safe. So this QR code that I've got on here is just a really helpful document for patients and healthcare workers, which gives loads of evidence base from the British Society of Sexual Medicine about all the options that we have for everybody, but particularly with a page on people that have been through cancer. And it's important if you're going through cancer, or if you've got patients who are going through cancer, to just encourage them to look after vulval health from the very beginning. So early use of vaginal moisturizers and lubes and emollients for washing is really useful. So my base layer I talk to with patients is that we should look after this on a daily basis. So use vaginal moisturizers a couple of times a week. Use an emollient to wash. Something plain that you'd use in eczema is fine. But for some women, that smells medical. It doesn't make you feel very sensual. So I sometimes talk about coconut oil, just the kind of stuff that you use for cooking, is just as good externally to wash and moisturize with. Pat dry after washing, be gentle with your detergents, use cotton underwear, and just to encourage self-awareness and checking. Skin changes start to get more common as we go through menopause. So things like lichen, which can potentially be precancerous, dermatitis, eczema, vaginal cancers, they're more common as we go through menopause and beyond. So getting into the habit of looking for thickened areas, ulcerated areas, discolored areas, vulval melanoma, no one even sort of thinks about that as an option, but you can end up with melanoma in the vulval area. So being conscious of that bit of you and looking after it's really important. Topical hormones, just a note to say that really they're super low dose in terms of absorption. So if you use it all year, then we know that the amount that you absorb into your bloodstream is roughly equivalent to taking a single 1 milligram HRT oral tablet per year. It's tiny. So we can confidently offer our patients and use these drugs ourselves without worrying about increasing the systemic estrogen level too much. We know that the symptoms return within about 6 weeks of stopping vulval and vaginal estrogens, and the NICE guidelines say that we should use them for as long as is needed. And for women that want to be sexually active later into life, or are worried about their urinary function or UTIs and so on, that's possibly lifelong. And just to note that sometimes we need to apply estrogen externally too. So the labia minora, the clitoral area, all of that has estrogen receptors. So sometimes I'll give women internal estrogen and some estrogen to put onto the external skin too. There's loads of different types. The market kind of expanded a few years back and people get a bit confused. I think it's very much about personal choice. Sometimes if you've got a history of a hormone-sensitive cancer, you'll want to use a really low dose one like Invagis, which is kind of the lowest dose that we've got, or an estring. But for most women, it's about whether you want a little tablet on a stick, whether you want to use a gel-based option. The Invagis is a little sort of waxy bullet, a bit like a pile suppository that you pop in with a finger instead. And the S-string is a flexible hair bobble sized device that you just push right up into the vagina and it stays there for 90 days. It can stay in during sex, but you can take it out if you want to. But the benefit of that is there's no residue. And sometimes I find my patients in sexology find that the residue from these products makes them feel kind of self-conscious. So S-string can be a good option. So the big one, the one that I get asked about all the time and all my referrals are about testosterone. And I'm sure that I prescribe testosterone more than most doctors, but it's not the only thing that helps. And what I tend to say when I'm teaching people about it or talking to women about it is, it's really important to ask yourself what happened first, whether the loss of libido happened on the back of sex becoming painful or joyless or not rewarding, or whether it happened first. And if your loss of libido, you've lost libido like you've lost hunger, and sex when you bother is still good, that's more likely to be a testosterone or estrogen driven problem. If it's coming on the back of problems with sex, then it's entirely natural and we have to think about solving the problems instead. This is a really messy slide and I've kept it that way because it's a really messy problem. So all of the stuff we've talked about already is in these boxes. All of these things interlink and cause each other. And then everything around the edge in your life also makes it even more complicated. So the overall sort of message is that it is really complex and we need to be curious and we need to sort of shy away from one size fits all solutions and just ask about all the layers of what's going on for people and in ourselves. What started it, what's making it worse, what else is going on for me? But yeah, testosterone is important as a hormone in the body. In terms of female sexuality, it plays a really important role. It's important in our brain and our interest in sex and fantasy and sexual thoughts. And it's important in the wiring and how the clitoris gets erect during arousal. So I, as a practitioner, I tend to make sure that my baseline is to kind of replace estrogen, replace testosterone, and then look at what's left and see what other things might be impacting. For those of you that are seeing patients, think about testosterone more in those patients that have had ovarian damage or either through cancer treatment, like radiotherapy or chemotherapy, or who've had them removed surgically. Make sure that if you're starting testosterone, you have given enough estrogen first through the body and in the genitals. And blood checks have just been changed in terms of recommendations. There's less advice about checking a blood level for testosterone first, but personally I still do that because I've seen the odd high one that I wasn't expecting. So I tend to do a blood level first and then again after sort of 8 to 12 weeks, depending on the setting that I'm working in. And we look at free testosterone these days more than SHBG, but really you're trying to map that the level that you're seeing on the bloods kind of corresponds with what's happening in women and that there's no signs of being over replaced. And you just have to remember that, I find that it doesn't it solves the problem far less than you might expect. Many more of my patients need some psychosexual, psychosocial kind of input as well as the hormonal side of things. So what are all of the psychosocial factors that impact sex at menopause? Well, there's millions of them, and I'm not going to be able to spend the time talking about every single one, but as a tour through, one of them is the myth that something has to be wrong if you lose desire for your partner over time. So there's this concept in sexology. There's a very prominent sexologist called Esther Perel who's done lots of nice TED Talks. She's written the 2 books that I recommend the most for couples who are experiencing loss of desire in a long-term relationship. One of them is called Mating in Captivity, and the other one's about infidelity, which is called The State of Affairs. And she's looked at this paradox that exists in long-term relationships. Early in a relationship, we're very hormonally driven with our sexual interest. But as we get to know our partner and we have a desire to attach to them and to get bonded to them, and that love attachment means that we want lots of warmth and we want lots of knowledge of our partner and to be very close emotionally. But desire and sexual interest is very much novelty based. We've even got something called the Coolidge effect, which tells us that when we are offered the chance of a new partner, even if we have a regular partner available to us, we'll make a bigger physiological effort for that sexual partner. So if you count the sperm count that's ejaculated in a new sexual encounter versus in with a current partner, there's more sperm, there's a higher volume of semen. The physiological arousal is greater in men and in women. Men are more likely to die having sex for the first time after a heart attack with a new partner than they are with an existing partner. So whether we like it or not, and whether it sits comfortably with us or not, novelty is quite important for eroticism, But what we want in terms of love and intimacy and warmth and connection and families is a kind of a very close bond. So Esther Perel talks a lot about this paradox and why that makes desire tend to fall in long relationships over time. And they've proposed the stairway to heaven, this erotic equation, which is that when we're attracted to something and there's some difficulty in getting it, we feel the most desire. So what does that mean for those of us in long-term relationships, or for those of us treating women that come in complaining of loss of desire and saying it's all testosterone based? It means that actually we've got to keep our minds open to the fact that psychosexual therapy is sometimes way more helpful in these circumstances than just HRT and testosterone. One of the key things that we talk to couples about is this idea of maintaining some individuality and some separateness within the relationship. So nurturing some time apart and some growth as individuals so that you can come back together with new things to learn about each other. And in that curiosity, sometimes eroticism starts again. It's a bit like you often find your partner the most attractive when you see them across a room at a party, or when you watch them doing their thing at work. That gap sometimes allows us to eroticize them again, rather than, when we see them day to day with their pants on the bedroom floor and, not looking so attractive in daily life. So that gap sometimes helps us. And we can actually build on the chemicals too. So one of the things we do in psychosexual therapy is sensate focus, which is this kind of staged approach of non-sexual touch, but you kind of build from, hand touch, shoulder touch, and back touch towards touching in more intimate areas. Part of that is about building confidence, but part of it is that when we're touched and we're relaxed, we release oxytocin, which is the bonding hormone, and that's the chemical that's really high early in a relationship. If you inject a bird with oxytocin and vasopressin, they start to sing mating songs. We're wired that if this stuff is going through our system, we're going to feel very attached to the person that creates it. So sometimes, a prolonged hug, prolonged eye contact is really important. And sexual currency, that kind of anticipatory chat that's really prevalent in an early relationship where we flirt and we talk about what we're going to do later, tends to disappear in long-term relationships. And it means that it's a long way to go from putting out the bins and working out who's going to get the supermarket shopping to feeling erotic. So we sometimes have to kind of build that scaffolding from one place to the other. And that's in terms of things like sexual currency. So we can look at that within our relationships and building that sort of space. And we have to remember that partnered sex is much more complex than solo sex. And when we've got two people having sex, it's been described by Karen Gurney, I think, as being like two musicians playing separate musical instruments trying to harmonize. We've got to kind of get our stuff happening at the same time as a partner, and that produces loads of problems for couples, managing others' response, managing performance anxiety, managing other health problems. So sometimes it helps to look at what's happening in solo sex and kind of compare it to what's happening in partnered sex. And just to be mindful that where sex is a problem, there's often a huge loss of communication. Many of the couples I see get on really well, but all intimacy is gone because there's a fear that if there's a cuddle or, a date night, or if you go to bed at the same time or go on holiday, that there's going to be a huge pressure to have sex, and that's going to be seen as a green light for intimacy. So couples start to really separate, and all intimacy can go away if we're not talking about things. So one of the most important things I do with patients after I've spoken to them is just to say to go home and raise the issue with their partner, that you're bothered about doing something to try and make it better, but to try and explain how you're feeling, because that loss of hugging and going to bed at the same time and that sort of non-sexual intimacy can feel really rejecting for the other partner, and can be sort of felt as a real sort of difficult thing. And testosterone won't fix that. The other myth I hear a lot is that desire for sex is spontaneous. We shouldn't have to put sex in the diary. And that's, I think, partly because in Hollywood films, sex is always really high passion and it's always very spontaneous. But actually, that's not how it really works in most people's lives. So there are sex scientists. People have studied what makes us interested in sex or makes us want sex. There was a Love Lab back in the 60s. And they came up with this idea that what happens first is we get excited. Then we get more excited and we reach a plateau. Then we have an orgasm, or maybe multiple orgasms if we're female. And then there's a resolution. And the resolution is a bit where you can't actually get aroused again for a little while because everything is kind of shut down. And then Helen Kaplan looked at that idea and said, actually, before we get excited, we need to have desire. But there's a lady called Rosemary Basson who did a model which is much more what we see in long-term relationships. And many of the women that I see at midlife are in a long-term relationship. And that's this idea that it's kind of circular. So don't get too hung up on the sort of the specifics of the diagram, but it's the idea that we can enter that arousal cycle at any point. So sometimes we will start to feel physically aroused before we actually want sex. So someone might touch us and it might spark something, and then we'll want to have sex. Or we might get a memory or hear some music or smell something, and it's that that sparks the desire. And also, really importantly, that only some of our desire is spontaneous, like hunger. A lot of our desire is receptive, which means that somebody will bring the idea up, and then we have to decide whether we're going to get involved in that or not. And there are what we call approach motivations and avoidance motivations. Sometimes we decide to have sex for good reason, because we're expecting a reward. We might want an orgasm. We might want to feel physically closer to our partners. It might make us feel good about ourselves. But sometimes women engage in sex because they're fearful of losing a partner, or they're fearful of an argument, or fearful of losing that part of themselves. So we have these reasons that we come out of this neutral place. And one of the really important things to recognize is that to respond to a sexual advance or a sexual sort of stimulus, we have to expect sex to be rewarding in some way. And many of the women that I'm speaking to don't find sex rewarding because it's either disappointing because they can't get aroused and climax, it's painful, it makes them feel bad about themselves, or they have some anxiety around it or some fear around it. And that's where you need to go to try and do something about the problem. That's where testosterone won't really fix things. So anxiety is something that we often think about with blokes, performance anxiety and erectile dysfunction, but it's something I see a lot in female-bodied individuals too. And this is because there's this idea that sex is kind of a delicate balance between the stuff that's kind of revving us up and all the hormones and the processes that get things going, and then the stuff that can slam the brakes on. And there are loads of physical things that we've spoken about already that reduce arousal. So loads of menopausal physical changes, anything in the body that's impacting nerve supply, blood supply, tissue damage, pain, and medications. And obviously we've talked about cancer as being a thing that can cause lots of physical breaks to go on. But there's also lots of social and psychological breaks too. So in relationships, if you're in a relationship where sex feels like an obligation or a duty, like a must do rather than a want to, that's a big break to arousal. If we're bored and we've been having the same kind of sex for years and it's no longer interesting, and we're with a partner that's not very good at it, if we feel that our relationship generally isn't one that's serving us very well, so we don't feel like our emotional needs have been met, or someone's just not putting their weight around the house and we're resentful, those things will mean that we've got a break on, and it's going to be really hard to access our arousal pathways. If we're not able to have the kind of sex that we want to have, if we're not doing the kind of activities or with the kind of partner, I sometimes talk about the Hugh Jackman question, which may say more about me than anyone else. But, if you think that things would get better if you had a different partner, then this is not really a testosterone-based or an estrogen-based problem. This is something else that's going on for you. And what helps sometimes is exploring, and many women I speak to have never explored what their wants and needs are. So some psychosexual therapy or some personal therapy to think about your wants, your needs, and how we can communicate that within a relationship. And then psychologically, anxiety is a massive, massive break. There's a condition in men called priapism, where the penis gets erect and it won't go down again. And the treatment that we give is to inject adrenaline into that tissue, because it blocks the arousal, sort of, the accelerators, and returns everything to baseline. And we release adrenaline when we're stressed, if we're anxious or afraid, and it absolutely is a bucket of cold water over our arousal pathways. So anything that causes anxiety and fear, anything that distracts us so that our brain is elsewhere during sex. And you show me a menopausal woman that hasn't got a million tabs open in her brain and a million things that she's trying to do at the same time. And dissociation, if you flip out of your body, so women who've got trauma histories will recognize this. Women who've been through painful surgery or painful conditions will recognize this. We get very used to leaving our bodies when something is unpleasant or uncomfortable, and that can become a reflex. So many women I speak to are nowhere inside their bodies during sex, and therefore they're not noticing pleasant physical sensations, or they're not sort of there. And those things are really important too. And it can become a vicious cycle. If we get anxious, we're less aroused, sex is more painful, less rewarding, and round we go. So from a psychosexual perspective, I encourage patients to focus on solo sex first. It's safer, it's only your arousal that you're concerned with, and it can help you to build confidence. I sometimes talk about remapping your body, especially if you've been through a menopause or cancer or another sort of physical journey where things may physically be working differently, to have curiosity about what touch you enjoy, what touch you don't enjoy, what works for you now. And to practice focus. If your mind is drifting, practice bringing yourself back online again and getting confident in how to do that. And often that's through mindfulness. It's noticing sensory input like smell, touch, pressure, temperature, taste, sound. And to practice mindfulness in your daily life. Most of us, I've been doing it today, zip around at high speed, doing a million things, always in our heads, because you've got so many things to do. And we actually can practice mindfulness all the time. So if you're in the shower, be in the shower, just notice the temperature of the water, the touch of your hands on your skin, what it smells like. If you're out walking, notice what you're seeing, hearing, smelling. And that practice will bring you back into your body, and you can take that into partnered intimacy, and it will help you to connect much better. And that's largely what Sensate Focus is about. And if you're feeling anxious generally, then things like CBT for menopause can really help. Medications for anxiety sometimes put the brakes on sex, so I tend to push more towards CBT. And the final myth, the sort of Davina documentary myth that makes me as a sexologist a bit cross, and I go to conferences about sex toys and things, so I'm not against sex toys and lube, but it's this idea that all you need to get a menopausal woman going is a really big vibrator and a bucket of lube and it'll all be fine. Drives me nuts. So just to say that, yes, there are some women who will need to intensify physical sensation. Our sensory nerves can get less sensitive as we get older, and sometimes we do need to ramp things up a bit physically. And there are ways of doing that. I recommend Yes Oh Yes oil, which is kind of a clitoral stimulant oil. It's a good idea not to use that till you've used vaginal estrogens and made the tissues a bit stronger there, but it can help with orgasm. It can help to experiment with temperature toys. I often recommend clitoral suckers, which are vibration can sometimes make you get numb, or you can sort of reach a point where you can't tip over. So clitoral suckers are available in lots of places, and they can be better for those that have lost arousal. But lots of other stuff needs to be done too. So we should address the physical and hormonal basics that we've spoken about. We should address relationship issues. We should look at anxiety, fear, distraction, dissociation. We should encourage a self-referenced model, explore your own body first, remap it. What do you like? What do you want? What turns you on? Go back to your erotic palette and explore what your brain turn-ons are at this stage of life. So there's quite a lot of female-friendly stuff out there. There's audio erotica, there's books, there's female-friendly ethical pornography, as well as the free stuff, which is much more controversial. So looking at that kind of thing can help to get your brain a bit more interested and bring the novelty back that might be missing. And to remember that sex is not supposed to be a predictable 3-course meal. It is a buffet, and you can dip in and dip out and have as much or as little as you want. And when you open it up like that in a relationship, it can really take the pressure off that one touch needs to lead to everything. And it can make people feel a little bit more comfortable and free about accessing their sexuality again. So my take-home message, predictably, is that there's no one size fits all message. Every woman that I speak to is very different and will need different things. All of these myths need to be challenged. We need to look at women in a body as a basic. Yes, do the things that are important physically, because they'll make it much more difficult, but absolutely recognize what's happening in their psychological state and also in their world, and not oversimplify this issue and suggest that it can just get better if you have testosterone and a vibrator. And this is I'll leave this one up for a bit longer. This is a list of some of the things that I do as a GP when I'm sat in that setting. I don't have much time. So I often just send my patients to these places to do some of this self-exploration. So there are, psychosexual therapists can be accessed through COSRIT, which is the body that trained me, or the Institute of Psychosexual Medicine, or Relate. But there are lots of books that bridge this gap. So the two that I think are best are Mind the Gap by Karen Gurney and Better Sex Through Mindfulness by Laurie Brotto. They're really useful books to be aware of. And I can take questions and have a drink.
Brilliant. Thanks, Angela. If anybody wants to raise their hand, come off mic and ask a question. I'll go to the chat box first and then we'll go to hands afterwards, if that's okay. Because there's a couple in the chat box. One of them is there a need for testosterone after a full hysterectomy?
That's one of the situations that I almost always use it, yeah, because if you haven't got your ovaries, then you've lost almost all of your testosterone, and it's very likely having an impact on sex, yeah.
Brilliant. Next one, it's more of a comment than a question. If ovaries have been removed, trying to get psychosexual therapy is a challenge.
Yeah, I mean, it's the reason I trained was as a doctor. I got so frustrated that I had nowhere to send my patients. I had no, referral pathways. But the books are really useful. The books can help you to start your self-exploration. So looking at those resources can be really helpful.
Brilliant, thank you. Next one is I've had breast cancer and on Antrazole to reduce estrogen as cancer was hormone related. Which vaginal estrogen should I be asking my GP, please?
So you'll need to take in a copy of the BSSM guidelines that I showed on the Q code. So I think this is going to be recorded, so you can probably go back and look at the QR code again. Those guidelines explain to your doctor, who might be a bit nervous about how to prescribe estrogen in women like you. Sometimes we talk to oncologists about moving to tamoxifen, not because of risk, but because it allows the estrogen to absorb in the vagina. So I would potentially get your GP to ask whether that's a reasonable switch in terms of your cancer. But if it isn't, it is safe to use low dose like Invagis, and lots of lube, lots of moisturizers with an anastrozole. And the guidelines, the BSSM guidelines, sort of show that and help to support that in a conversation with your doctor and with your oncologist. They're variable in how confident they are.
Thank you. One comment here. How do I get to see you as a GP? Do I need to move house?
Yes, I work in multiple settings. I do free bits with Maggie's, so we regularly show up at Maggie's. I work in Hull NHS and in Massam North York's NHS, and I work online. I've got a private clinic as well, so I'm available that way.
Wonderful. What can be done about painful orgasms?
Oh, interesting. Yeah, there are things that can be done. So it's always difficult. You could do with someone who someone like me. You can take medications. You've got to figure out what it is that's causing the pain. So there's questions that I would ask to try and work out why. And it might depend on whether you're in your fertile years, whether you've got hormones, what else is going on in the pelvis. Sometimes it's physical stuff, but there are medications that we use as well sometimes. The ISSM website, if you go on the International Society for Sexual Medicine, they usually have good resources. So if you look on there, you might find a nice list of sort of things to help you to understand the cause.
That's great. Another comment here. I've had skin cancer. Is this an issue with HRT if needed?
No, so melanoma occasionally has some links with estrogen receptor positivity, but we've got no evidence that shows that HRT is harmful. Usual rule is if you write to the oncologist to check, they can sign off and say that it's fine.
That's great. Another one is just mentioned, missed the start of the session. Please recommend the testosterone type and dosage and lubricant. I'm also on blood pressure meds and had a full hysterectomy.
Okay, so you probably do need testosterone. The British Menopause Society guidelines, which I put a QR code up for, there's 3 different products on the NHS that we can use. There's Tostran, Testim and Testogel, and they're all on the BMS website, and it's 5 milligrams a day, whichever one you're using, so your doctor can follow that. You don't need Androfem. It's more expensive and there are NHS options.
Just when you said BMS, just for anybody who doesn't know what BMS is.
British Menopause Society. So they've got a nice consensus statement that kind of guides your doctor on what to do. And with regard to the blood pressure drugs, there are some that are better than others. So if you get onto an ARB, a sartan, that's much better, and a calcium channel blocker is much better than an ACE inhibitor like a ramipril. So switching drugs can really help.
Brilliant, thank you. Looking at testosterone to add into my oral HRT estrogen, only has had a total hysterectomy. GP has referred me to a menopause clinic, but don't know how long the waiting time is going to be. GP is suggesting I should change to topical estrogen. Would this be less dose?
So generally speaking, if you're on oral estrogen for systemic HRT, it does mop up your testosterone a bit. So it's better to have it through the skin, like a patch or a gel or a spray. I give everybody vaginal estrogen because those bits of you need to be working well for sex to work well. And you can have both together routinely.
Brilliant. I'm on HRT gel and progesterone pill daily, but I don't want to take any meds anymore. I've suffered badly at the beginning of COVID, so ended up on HRT. Could I be damaging myself or putting myself at risk from anything not staying on HRT?
No, and that's one of the myths that needs busting. A lot of the kind of celeb noise makes you feel like you're definitely going to get dementia and osteoporosis and heart disease if you don't have HRT. Lots of women don't want it, and as long as you look after your health generally, that's fine. So just look after your heart health, make an effort to look after your bones and do other things instead. If you don't like it, you can stop.
Brilliant. Thank you. And we'll go across to Shani. Do you want to ask your question?
Yeah, is there any evidence that use of vibrators over a lot of years does any damage to the clitoral nerves? And I also wanted to ask if the estrogen gels and things are safe for our partners in oral sex.
Okay, good questions. No, the opposite. We know with vibrators that you can reach a plateau in terms of stimulation. So it's quite common that people get numbness and they end up like ramping up to a stronger and stronger and stronger vibration to be able to reach climax, which is why I tend to recommend the clitoral suckers instead, because they kind of puff on and off, and that's a bit better. There's evidence for gentle vibration in tissue quality. So like massaging the tissues, gentle vibration helps with blood flow to the vulva. And then I forgot the second half of your question. It was a bit about that, then there was another half.
Yeah, whether the gels and things have any impact on the partners if you're engaged in oral sex.
No, so they reckon that about an hour after putting your estrogen in, you should avoid penetrative sex. But in clinic, what I tend to do, because we allow estering and we allow you to have intercourse with estering in, the evidence that this is based on is really rubbish. There's not a lot of research that suggests it's a problem, but sort of anecdotally, we often say wait about an hour after putting in Vagirux or Vagifem or something before you have intercourse. For oral sex, we won't have studies. Nobody's done anything half as useful as that. What I tend to say to women that want to engage in oral sex, often estering is better. It doesn't have any discharge or residue, and it means that you're getting the estrogen delivered, but not having to worry about anything coming away, and just taste issues as well. Sometimes that can be a problem.
Thank you.
Another couple more just come into the chat box. Is the contraceptive pill something that may be prescribed rather than HRT for ladies in their early 40s? Would this balance hormones in a... Oh, I've lost it now. Another one came in. Would this balance hormones in a similar way, or is it totally different from HRT?
It's a different form of estrogen, so it behaves differently in the body and it's less bone protective, and it's oral, so it has different risks, and it also mops up some of your free testosterone, so it's quite common that it causes a dip in libido, and it can cause vaginal dryness, which feels really counterintuitive, so sometimes you need to be aware of that. So if you're early in menopause, we still tend to go for the HRT drugs. In higher doses sometimes, we still use those sort of chemical versions of estrogen and progesterone. They're better.
Another question on what should I buy for daily vaginal health?
So you can just if you don't like using emollients, so I would always say Epiderm or something like Zero Base, just the kind of eczema emollients that most of us are sort of familiar with. Washing with that, moisturizing with that is ideal. Because of the work I do, and many of the women I speak to are sort of, they're not even sort of neutral about sex, they're sort of a step back. Sometimes from a sensuality point of view, I like using coconut oil because it's got a better smell, a better texture. It feels more like putting something nice on you rather than something medical. And in many years of use, I've not seen women with problems. You can't use it internally. You can't use it, if you're prone to thrush, you might need to be a bit careful that it doesn't go inside, but it can be an alternative that some women like.
Brilliant. And we'll go to the last question now, which is, if vaginal dryness isn't an issue, would vaginal estrogen still be needed? concerns on topical treatments due to sensitive skin reaction issues.
Okay.
I have a reaction to very sticky things on skin, even clothing sometimes.
Okay, so yeah, if you're not struggling with dryness, that's not the only sign of change in the vaginal tract. If you've got systemic estrogen in the form of HRT, then not everybody needs additional vaginal estrogen. Some women get enough from their blood supply. The work I do, I tend to give women a trial of 4 weeks anyway to see if things get better. And you should be able to find a product that would be okay. So for example, to look after those tissues, keep them stretchy, preserve the bladder, all of that stuff, an estering would be quite a sensible option, because it's not residue, it's, you know, it's a ring, it just sort of emits it, and that's probably something that you'd get on with.
Brilliant, thank you very much. Is there any more questions to come? Hands up, or forever hold your peace. Shania, you've got your hand up again. Is that
yeah, just a quick one. If you're using propranolol and it's working beautifully for migraine prophylaxis, would HRT get in the way of that?
No, not at all. So HRT wouldn't. From a sex perspective, propranolol is one of the ones that's more problematic. From if you extrapolate from men and what causes erectile dysfunction, and like I said, the tissue's the same. The beta blockers aren't great, but nebivolol is one of the ones that is better. So sometimes if you do notice there's changes, switching between different drugs can sometimes give you a different impact. And the ISSM has a nice list of all the drugs that are problematic for sex. So you can kind of have a scan. There's hundreds of them. I'd have to have like 5 slides to stick them all on.
Okay. Thank you.
Okay.
Brilliant. Well, thank you, everybody. Thank you for joining today. It's been really interesting, especially for me as well. It's not going through the menopause, but and thank you for Dr. Angela Wright, and thank you for all the questions. I think I put a link in at the very beginning, just with some of our the recordings will be sent out next week for all the sessions, so you will be getting a link to any of the sessions that you did miss this week, as well as this one as well. So thanks again, and hopefully you enjoyed it as much as I did, and we look forward to seeing you all very well again soon.
Thank you. Bye.
Thanks a lot. Bye bye. Thanks, Angela.
That's okay.